Well, good afternoon and welcome to CEDA's Healthcare After COVID-19 live stream. My name's Melinda Cilento and I'm the CEO of CEDA, and it's great to have you joining us for today's live stream event. Can I start by acknowledging Aboriginal and Torres Strait Islander people around the country and acknowledge that we are meeting on Aboriginal land. I live here in Melbourne, and so I'm on the land of the Wurundjeri people, and I'd like to pay my respects to elders past, present and emerging. We're having a conversation today about healthcare and our healthcare system and how it's performed. It's probably a good opportunity to just take a moment to reflect on the health outcomes of Aboriginal and Torres Strait Islander people and the importance of making sure that as we move forward into the future, we actually think about how we can improve those health outcomes in the months and years ahead. I think obviously healthcare and its importance has been absolutely front and centre in the minds of all Australians in recent weeks and months. When we think about how we've managed this crisis in Australia, I think we're pretty proud of how we've done that broadly, but also in respect of how our healthcare system has adapted and met the needs of all Australians. So I think there's a lot that we can talk about in terms of how we think the healthcare system has managed to date, but also importantly about how some of the things that we have become used to in our healthcare system have changed and evolved, and how we can learn from those changes and think about how we can continue to improve our healthcare system in the future. Lots to talk about today. I'm sure lots of interesting questions from our audience I'm sure we'll be getting, so looking forward to that. Let me just take you quickly through the order of proceedings for today. I will in a moment introduce our keynote speaker, the Minister for Health. He will speak for roughly 15 minutes and then we'll do some Q&A. And then I will introduce a couple of our expert panellists who will continue the conversation on in a Q&A session that will run through until about 1:35 this afternoon. So that's roughly how we're going to roll with things today. As always in CEDA's live stream, if you are interested in engaging, you can do so asking questions through our Pigeonhole app. You can click the link at the bottom of your live stream page and it will take you there, or you can go to ceda.pigeonhole.at, and the password for today is OzHealth. We also love it when you can engage through social media. If you're going to do that, for example, through Twitter, make sure you tag us at CEDA_news, and the hashtag is #OzHealth as well. So without any more from me, it's my great opportunity to introduce to our live stream today the Health Minister, the Honourable Greg Hunt MP, who's also Minister assisting the Prime Minister for Public Service and Cabinet. Greg, welcome.
Look, thanks very much to Melinda, to Elisabeth, to Rod, but to everybody who's watching today and participating, and for your work through CEDA directly, but more broadly in terms of providing employment and investment and all of the things that are helping to drive the economy forward. So we know this has been an immensely difficult and stressful time for so many people. To put all of this in context, as we look around the world, today the numbers have passed 10 million officially diagnosed cases. We think that it's significantly greater than that, particularly where you see case fatality rates over 2 or 3%, 2% in developed health systems, 3% in those that are more developing. And we know that 500,000 lives have now been officially lost, but clearly the real loss of life is very significantly higher, not just in developing health systems, but in developed, in Spain and Italy and France, the UK and New York. All of the authorities recognise that the actual loss of life is likely to be significantly higher than they were able to account for in the early weeks and months. against that background, where we are as a country, about 7,760. I'm just waiting for some final numbers from some of the states and territories. About 7,760 cases, very sadly 104 lives lost. Nevertheless, by global standards, Australia's outcome has been an extraordinary achievement. And that's a partnership which has driven that, and that's what I want to, Melinda, go through today, that partnership and how the structure of the Australian system has responded and how there will be ongoing legacies which flow from that for the way health is provided and delivered in Australia. The partnership is the Commonwealth, the state and the population, all three of those elements, the states, the general population, which has overwhelmingly been magnificent, and the Commonwealth. I do have to say, we are clearly having what we regard as a very serious spike in Victoria now. There's no question about that. The numbers today of 75 represent the most serious outbreak, and I've said this in an interview just shortly coming on with you, before coming on, most serious outbreak we've had since we began to flatten the curve in early April. So against that background, we set out to deal with this through containment, the flattening of the curve, the reduction of numbers, and capacity, increasing the ability of the primary care, the aged care, the hospital system, and the research components of our health economy to manage what is clearly now a massive and ever-growing global pandemic. Just to put that containment challenge in a little bit more global context again, not only is it 10 million plus official cases, the rate of growth is continuing to increase. When I last looked, I think 5 of the 6 highest days were in the last 5 days. So globally, what we're seeing is that each successive million is being reached at a faster rate than the million beforehand. And that's a very concerning outlook. It means that the global situation, whatever our challenges domestically, the global situation is real and accelerating through Latin America, sadly through North America again, Eastern Europe. There's been very good movement in the EU and now the UK numbers have been beginning to drop. The Middle East, however, is also expanding very quickly. South Asia, very significantly, India, Pakistan and Bangladesh. And now we are seeing growth in Africa. And we think that the reported numbers are, because of the nature of the health systems in many of those countries, likely to be well below the reality, and the reported loss of life is likely to be well below the reality, particularly with vulnerable populations. So our containment strategy has been built around 4 pillars. And I think it's important to recognise that in 7 out of 8 states and territories, we are at effectively 0 community transmission cases. Some hotel quarantine cases, but that's hotel quarantine doing exactly what it should do, bringing people back in, but providing a safe buffer for Australia. Now, firstly, of the 4 pillars within containment, there is the border control. And the 1st of February decision, I think, is in many ways one of the most important one-day decisions that any government has made in the last 50 years. To close the borders with China was a massive decision, but we took it because we foresaw what we thought was likely to be a major spread, and that's been one of the things that's protected us, along with the subsequent decisions in terms of Iran, Korea, Italy, enforced isolation, cruise ships, and then the total border ban and quarantining for those returning Australians. The next thing is in terms of the tracing the testing system. We're now at over 2.3 million tests, testing over 40,000 Australians a day. That number has more than tripled, and so we are up in that order which we set out to achieve. And in particular, when in Tasmania there was a localised outbreak, we focused on testing all of the people who were contacted or in particular areas. Where there is an aged care outbreak, we automatically test every resident and every staff member. Now we're pursuing through Victoria a localised testing strategy, which is seeing tens of thousands of people tested, both symptomatic, obviously, but asymptomatic as well, because they might be in the last stages of asymptomatic, and so the virus might be detectable through the PCR or polymer chain reaction tests. Related to that testing expansion is, of course, the tracing. Now, the tracing has two elements, the human and the electronic. The human element, we've ramped up public health around the country and we're diverting resources where they need. So South Australia, Tasmania, New South Wales, Queensland, WA, they are all contributing to what's occurring at this point in time in Victoria. So they're bringing forward their resources and doing that work. Equally, the app is now 6.5 million downloads, or just about to reach that. It's doing what it's meant to do. It's actually been used for multiple contacts. It's identified people that otherwise had not been known. It simply serves to indicate where if you've been next to somebody on a train, on a bus, you might not know who they are. Circumstances have meant that people have been closer than ideally they should have been. So it's an additional component over and above. But that tracing regime is immensely important. It's a major job in Victoria now. As the case numbers grow, each of them could potentially have been exposed to 100 people. And then that means that those people have to be isolated and they have to be tested as well. And then last of all, we've had the physical distancing, the social distancing measures, the lockdowns, which have been immensely hard economically. We've seen that where we've had a huge economic blow and jobs have been lost, people's businesses have been put under pressure. Obviously, the JobKeeper and JobSeeker have been put in place to support that. We're now working through the next stage of that post-September 30, but the Prime Minister said there would be a next stage. And we're spending a lot of time planning and thinking through what are the projections for the economy, recognising the international situation. But in terms of the protection of the public, this element was immensely important. As we've designed operations going forward, we've said, well, where there are outbreaks, and we've always said there would be outbreaks, we would have to have testing, tracing, but also the potential for local solutions. North West Tasmania had a lockdown. We've conveyed to Victoria that we would be supportive if they chose additional local measures. It is harder in an urban environment that, a township is easier to ring fence than a suburb, but the capacity is there, and we've passed that message to Victoria through multiple channels from the Prime Minister, myself and the Chief Medical Officer, among others. Then, having done all of that, knowing that there will be peaks and troughs, there will be outbreaks. Now we have the one outbreak that's a serious outbreak in Victoria. At the same time, we were building the capacity. And we did that to make sure that if there were a mass outbreak, we were able to manage the primary, the aged and the hospital systems. To put it all in context, at this moment, there are 11 people in hospital in Australia. I think there are, so it's 11 in hospital. There is 1 in ICU, and at this point there are none on ventilation as a result of COVID-19. The primary care system did face a massive challenge in late March and early April. People were drawing home. Doctors and nurses were understandably seeing what was occurring in Italy and Spain, even in New York and the UK, where there were enormous numbers of infected healthcare workers and many deaths, agonising deaths, to see that. And as a consequence, we introduced the telehealth system. Now, this was always intended as a planned structure. We were going to introduce a limited version of that for seniors from the 1st of July. But that was a 10-year migration, Melinda, that we were planning. Instead, we were able to introduce universal telehealth for whole of population in a 10-day period. It was a lesson in speed. And then what we've done is we've made adjustments in different tranches or stages. And we've been doing that right the way through. But we're now at approximately 17 million telehealth consultations. As a result of those 17 million telehealth consultations, we've been able to keep people at home. We've got a system that we intend to be a long-term system. We'll have to adjust it to make sure that it's not in any way, shape or form subject to overuse by some sectors, as occurred, a small number of sectors or players, as occurred with the after hours in-home a while ago. But the AMA, the RACGP, the College of Rural and Remote Medicine, they're all committed to that project, and we're designing that with them now. So an emergency change, but with a permanent implication for Australia. The Shifting the Dial report said that telehealth is likely to produce at least 300 million of economic benefits per annum in terms of efficiencies, as well as, of course, all of the patient benefits. Part of that, what we've seen, is the transformation of the mental health system, where many people are actually maintaining a much higher rate of attendance through online consultations than would otherwise have been the case. Aged care, one of the extraordinary things is that we've had less than 0.5% of aged care homes have infected residents. We've still had losses, particularly Dorothy Henderson and Newmarch, very tragic. But when we look around the world, the lockdowns that we had, as difficult as they were, have prevented the extraordinary, agonising loss of life that we've seen right across so many of the developed world countries, Canada, the US, UK, France, all of these have had terrible losses. So that's been critical. And then the hospitals, we had to prepare for the scenes that we saw in Italy and Spain early on. We went from 2,200 to 4,400 to achieving our goal of 7,500 ventilator bed capacity. We struck a partnership with the private hospitals, and in terms of systemic reform, we struck a reform with the state, with each of the states and territories, and then achieved the pharmacy agreement, the 5-year pharmacy agreement, and the 5-year hospitals agreement through the course of it, which includes incentives to make private health insurance more affordable as we go forward. So systemic reform in the middle of the crisis. Lastly, over $350 million going into vaccinations and research, and a new National Centre for Epidemic Preparedness with the CSIRO, and on top of that, 66 million directly into vaccines, into therapies, antiviral treatments. So that's a quick summary. We're progressively planning the way out. We always said there would be steps and outbreaks and challenges. 7 of 8 states and territories have effectively zero community transmission at the moment. New South Wales might have an occasional case, but they're doing extraordinarily well. Victoria is our challenge at the moment, and we're very focused now on supporting them as they respond. And that gives us a pathway out. The international borders, we're going to use hotel quarantine for students, for high-skilled, for high investment capacity, and maybe further down the track for people who are going to come in if they want to be long stay tourists and they're willing to pay for their own 2 weeks accommodation and accept that they would have to have 2 weeks hotel quarantine. But those international border restrictions will be with us for quite some time. So that's a quick summary.
I almost forgot to unmute myself then. You'd think I'd be used to that by now. Thank you, Minister, for that excellent summary. Can I just mention that I happened to be on a phone call last week, towards the end of last week, with a bunch of my peers, if you like, from like organisations around the world talking about how they'd managed the crisis. And I have to say, at the end of that call, it felt like Australia was a very good place to be, I have to say, in terms of the response and the way my colleagues were describing how their governments had responded. And I have to, for many of them, it had been a lot more up and down and not the sort of consistency of approach and the collaborative approach which seems to have characterised what's been going on in Australia. I'll come back to the issue of collaboration, but I would love to just ask you, just talk a little bit more about the pace of change of telehealth, and it's something people have been talking about, and as you said, the Shifting the Dial report highlighted the opportunity to really advance telehealth and to use it to deliver better health outcomes and more affordable health outcomes. What do you think the lessons are that we can take from that example, but also, you know, examples that are probably less well known around how better use of data has been able to lead to better diagnosis and tracking of individuals?
Yeah, so we were able to bring forward a series of items. Now, in different ways, shapes or form, they were being prepared. We were going to move to a voluntary patient enrolment trial, very significant trial, for seniors from the 70 years and above line from the 1st of July. Because we had some of that architecture in place, we were able to rapidly build on that. That allowed us to make the decision to go to whole of population telehealth, and the nature of it was we were able to make adjustments as required, you know, to add some specialties, to add some particular types of consultations, and to do it in tranches. At the same time, we also expedited variations on the e-prescribing and the home delivery. So that became a protection model for seniors. It brought the pharmacies into play, and it kept people out of, you know, high contagion areas, pharmacy and at the same time, so pharmacy and also the general practice surgery. Also ramped up with the testing, over 500 different mobile or, you know, pop-up testing units, all financed by the Commonwealth, either half financed or fully financed, over 130 GP-led ones, which the Commonwealth has funded, another 30 for military centres, and then over 340 co-funded with the states. So what that said is we can move very fast. We had a pandemic plan, was viewed by the World Health Organization a couple of years ago as being probably the most advanced in the world. It turned out we were able to execute it, but then we, of course, had to design and move in terms of PPE and other things. One thing that you could never plan for. Who would know that, or nobody could predict that in a global outbreak, the centre of global mass production, Wuhan, would be the first place to be hit. So there was a massive supply shock at the same time as there was an enormous demand spike, but we were able to manage our way through with a daily focus on all of the consumables. And so we set up procurement units and planning units in early February for both in industry and in health for each of those.
Minister, do you think that the benefits that we've seen and that the community has enjoyed as a result of this rapid transition to telehealth and so many of the other things that you've spoke to is going to change the appetite or the approach to broader health reform? Do you think we now have got to a stage where people might be more accepting of the benefits of using data, of sharing data, of looking for technological advances that can actually deliver better healthcare at lower costs, in a way that perhaps has been a little bit more risk aversion or reluctance in the past?
Look, most people, I think, are absolutely fine with this. It's a 90%. We went from very few in relative terms on My Health Record. We had we moved to an opt-out program. We're now at over 90% of Australians approximately have My Health records. Our real challenge there is not the population acceptance, it's building the data, and that's been a very important part of what we're doing with the GPs and others. So I think the general population, you'll have some on either side who might be concerned, and that's why we've made all of this voluntary. But all research is ultimately data-driven. We've been able to set up a national drug discovery centre with over $20 million based at Walter and Eliza Hall Institute, which is effectively a rapid testing program using mass data for new vaccines, therapies and treatments. It's not the place, or the drug discovery centre isn't necessarily developing a particular cure for pancreatic cancer. It's trialling all of the different therapies and drugs that reach the threshold as being high potential around the country. So that database through primary, through the hospitals, where we've now set up a national centre for the exchange of hospital data, and through research is occurring around the country. So I think most people are fine. Some will have concerns about the deep state, but we've let everybody opt out. And so I think that's the critical thing.
Thanks. I might just go to some of the questions that we're getting in from our viewers, if that's okay for you. And let's just follow up on this particular theme, which is, I've got a question here around, will the government assess what policies may need to change in order to mobilise greater investment in the commercialisation and production of health technologies beyond basic research?
Yes. So what we have now is a high degree of international interest, building on what was already a high degree of international interest for clinical trials and for research in Australia. Many of the systems in other countries for non-COVID research have had to be put on deep pause. The ability to do clinical trials in non-COVID areas is very hard. And so as a consequence of that, we know already that there's an interest in rapid movement for phase 1 and phase 2 and parts of phase 3 trials to Australia. We are now moving with the states and territories to set up a one-stop shop for ethics approval. Medicines Australia came to us and they said, if we could ask for one thing at this moment on investment in Australia, it's not a change in tax settings or anything else, it's the one-stop shop for medicines approval, for clinical trial approvals. We were already onto that, but we're doing that now through the National Cabinet. And if we can have, one university's ethics approval recognised around the country, so if there's a standard and institutions are included, then that will expedite that investment process. And the pharmaceutical companies have said, and that will bring more general investment in basic research as well as potential for advanced manufacturing to Australia.
Yeah, fantastic. I've got a question that goes back to telehealth as well, quite a specific one around whether the government will help non-profit primary healthcare cover the costs of offering the telehealth.
So it's, of course, covered by Medicare now until the 30th of September, but I gave a formal statement to Parliament in what would have been budget week on the health progress to date. As part of that, I made the statement, which was agreed with the Prime Minister and the Treasurer, that our goal was to make sure that telehealth was an abiding legacy. So the Medicare side of it is there. We're also seeing an uptake through the private health insurers for non-Medicare related items. So if there is something specifically that the particular audience member would like to take up with me, if they could email me on all one word, ghuntmp, all one word, at aph.gov.au, and very happy to help.
Yeah, great. You might get a few more emails.
I may regret that. That comes direct to my phone.
If you need us to edit that out before we put it on the website afterwards, you'll have to let me know.
Everybody already has it.
I'm sure you're expecting this question, but one of the questions that's come through is around the COVID Safe app, and how essentially how we think it's travelling in the context of actually helping effectively track and catch people who've got pick up people who've got the virus. How are you seeing that, and are you satisfied with performance, and is there some lessons to learn here in terms of what we might do differently in the future more broadly?
Look, in terms of if I would review where we are, if you told me when we launched it that by now we'd have just about 6.5 million, I'd say that's ahead of expectation. It's been used in those states that have had cases. In Victoria significantly, in New South Wales where they've had fewer cases, they've used it. It's identified contacts, which have also in many cases been identified by contact tracers, but it's also identified people who have not been identified by the contact tracers. Our case numbers have been very small, almost non-existent in 7 states and territories outside of hotel quarantine. So the performance, it actually works. I've seen some of the tech people, but they were opposed. Somebody I saw last night was vigorously opposed to My Health Record, does not believe that the government should have any electronic health records, and has an ideological predisposition. That's a legitimate viewpoint. It's not one that I share. It's not one that the opposition shares. So the answer with the app is it does work. We've just had very few cases, but it's been used as a standard part of the workflow in those states that have had cases.
Thanks for that. I'm going to take it up at a slightly higher level if I could, and join 2 questions if you don't mind. I think one of the key kind of debates that's just sort of been at the backdrop of this whole crisis is economics versus health outcomes, and how we grapple with those as a society. And I know from CEDA's own research that when you ask the community what really matters to them, they go straight to things like healthcare, aged care. I mean, those core critical services that influences their health and well-being. But there's been this sort of trade-off conversation going on. So I'm just interested in how you think about that. But then also, you talked about collaboration, and the state-federal collaboration and national cabinet has really transformed that. So I'm just thinking about how you think then about economics versus health reform and that process of collaboration going forward.
Yeah, look, I don't see them as a trade-off. I see them as complementary. The example being, obviously, we've been fortunate to have outcomes that, by every objective criteria, you would say are far preferable to those in so many of the European and North American countries. And at the same time, during the peak of the Australian lockdowns, the City Map and Mobile Index, for example, had Melbourne and Sydney traffic and transport use at being 13% of the usual. It had Barcelona and Milan at 2% and 3%, and had New York and San Francisco at 5%, and I think London at 7%. So in other words, even though they had outcomes that in the health sense were far worse than ours, they also had economic impacts far worse. And that's been recognised by both the OECD and the IMF. I think the IMF said, last week the IMF said that we were on track to have a 4.5% impact on GDP this year. We think that's probably about right. That's a terrible impact, but it's the second best of the developed world. It's likely to be significantly ahead of many of our, fraternal countries that will see not just 8 or 10, but 12% and above hits to GDP, which translates to people's livelihoods, their jobs, all of these critical things. So, at the highest level, we see the two as complementary, not in conflict. That's why we made the decision on the 1st of February, when many thought it was an overreaction, the World Health Organization. Yes, we were criticised by China. We respectfully disagreed with both. we saw Canada and the UK continue to keep their borders open. Many in the education and the tourism sectors said, well, gosh, if they're keeping their borders open, that puts us at a competitive disadvantage. We said, look, I'm terribly sorry, but please understand our belief, our epidemiology predictions are that this will lead to very significant growth in case numbers. It will take time, but then it will accelerate. And sadly, that's been borne out, but it's reaffirmed that the decision to prioritise the health security has led to the best possible economic outcome in the most difficult situation. That's been our fundamental framework. Even this morning, talking with the Prime Minister about the Victorian cases, we recognised that if they needed to take stronger local lockdown measures, we would give them all support necessary, as well as the logistics, as well as the resources, but to give them that moral support, both publicly and privately, that recognise that those health outcomes would drive everything else.
Thanks, Minister. I've got a question going back to telehealth again from Professor Mal Thatcher from the Queensland University of Technology, who in your earlier comments, you did talk about the risk of overuse, I think, of telehealth. And basically his question goes to questions of affordability and whether or not the government has forecast the future likely cost trajectory of telehealth and its affordability on the system more broadly.
Yeah, no, look, thanks, Mal. That's a really important point. What we saw was during the latter part of March, right through April and through the first half of May, a significant dip in face-to-face consultations, which was expected, significant on-ramp of telehealth consultations. They have stabilised and the AMA and the College of GPs have both proposed to us that as we look to make this a permanent whole-of-population legacy, they want to see safeguards put in place. So they're coming back to us with proposals around the need for an ongoing relationship with a general practitioner. They're proposing looking at percentages and balances. So they are themselves taking the lead because they know that it needs to be sustainable. Now, we're obviously encouraging them to take those options. So we do look at this, absolutely, but we've now had a more than 3 months trial. We've had a 4 month whole of population trial, and it's overwhelmingly been a major and important addition to the system. It hasn't blown out, but we're taking steps now to make sure that it's a complement to, not a replacement to face-to-face. The general practice community, the specialist community are absolutely of that view. But there, of course, is a role, particularly mental health. It's been a very strong addition to the system. Prescriptions for people, and it might be somebody who's at home with sick kids. It might be somebody who's in a work environment where they just have to be physically there. These are both the economic and the social benefits as well as the health benefits. So now we've looked very closely, but fortunately we have some negotiations. It's understandable that we're trying to get the best outcome for the taxpayer, the partner, the private sector partner, was trying to drag you one way. And so you have to find a landing pad. On this occasion, everybody's converging on the safeguards for patient health, but also they become against any overuse. And so the private medical authorities, the colleges, the associations are in a very, very constructive place on this.
Well, thank you for that. And I think everyone's quite excited by the idea of all the players aligning on the same page and focusing on lower cost healthcare and better outcomes. Can I just pick up on the mental health point? We've got a question from Rajesh. Sorry, Rajesh, I'm going to not pronounce your last name. Really just questioning what sort of impacts we might expect this crisis to have had on certain members of the community from a mental health perspective. And they've called out the aged and younger Australians in particular, but I'm just wondering if you might just like to finish off by talking a little bit about what we think the mental health implications might be and what you've put in place systems-wise to provide support for those issues.
Sure. So in terms of the problem and the response, problem is absolutely natural that there are three categories, and it's less about demographics but more about causes. So three categories of those that are most likely to be affected. One, groups that are concerned about their health. And in particularly that was initially the elderly, but also those with chronic conditions and Indigenous Australians. One of our great successes has been, even though there's an Indigenous population of approximately 3% of Australia, less than 1% of cases have been in Indigenous Australians, and none, to the best of our knowledge, in any of the remote communities where we were most fearful, along with our aged care homes. Two, there are those that have been affected by the isolation and the lockdowns. Now, that is receding as an issue. Both of those were transient issues, but that's receding. And then three, there is the economic impact in terms of job loss, fear of job loss, or anxiety around a mortgage or a small business or even a larger business. And they are very real and likely to be prolonged and ongoing effects, because the global economic impact will have an impact on Australia, and the inability to do certain things in terms of mass gatherings and mass international transit will both have an impact on the economy going forwards. So on that front, we've had three major tranches: an initial $74 million package, which was aimed in particular at making sure that there were counselling services. Secondly, there was a pandemic mental health plan, one of the first, we believe, in the world. That's a $48 million plan, and that itself was focused on especially communications with cultural and linguistically diverse communities. And then thirdly, we've had the expansion of youth services through Headspace, and that's a $24 million package. So all of those three things have come together, coupled with the fact that almost half of all MBS mental health consultations are now done over telehealth. We're informed anecdotally, we don't have formal data yet, but a much higher attendance rate, so a much higher percentage of scheduled sessions are being met. People are, in many cases, more comfortable doing a video conference or a phone conference than necessarily going into a surgery.
Yeah, we've had some fantastic feedback as well from different speakers. We had Julia Gillard speaking on behalf of Beyond Blue and just talking through some of these changes and how it's made such a big difference to people trying to grapple with these issues. And very similar story that you were just speaking to, Minister, in terms of the ebbs and flows of the challenges of this crisis for people in terms of their concerns around their own health and well-being, concerns about their income and the like. Minister, I'm conscious that we've slightly overused your time already, so I just wanted to, on behalf of CEDA and our viewers, thank you very much for taking the time to give us an update on where you see things, some of the lessons for us around how we've managed things successfully, and the opportunities for us to continue to improve the delivery of healthcare in Australia into the future. We've got a live poll running around priorities for reform and outcomes in the future. I'll make sure, now that I've got your email address, that we send the results through when we're done, and I'm sure you can expect a few emails from our viewers. But thank you again for your time today, and we look forward to getting you back on the CEDA stage, virtually or face-to-face, in the near future. Thanks,
Melinda, Elisabeth and Rod, and to everybody. I know it's been tough, but as a country, it's been extraordinary the way we've adapted. And yes, there's another challenge now, but ultimately, what do I think? I think we will get through this, and we'll get through it in a better way than almost anybody else. And it will take some time to catch up in some areas such as employment, and that's our responsibility to help. But I just want to say thank you to everybody for everything that you have done.
Thanks, Minister. All the very best as we grapple with these challenges. Slight change of pace now for the audience. Let me introduce and welcome to our live stream our two panellists who are going to share their thoughts and views around the opportunities for our health future in Australia. Joining us, we have Elisabeth Staudinger, who is Head of Asia Pacific for Siemens Health and Ears, and Professor Rod Hicks, who is the Director of Molecular Imaging at the Peter MacCallum Cancer Centre and Professor of Medicine and Radiology at the University of Melbourne. Thank you both for joining us today. Perhaps I might start off with you, Rod, just any sort of thoughts on the Minister's comments, but also perhaps just a quick rundown from you around how things have been different from your perspective through this crisis and some of the things that we've done differently.
Yeah, thanks, Melinda. I'd certainly like to endorse the comments made by Minister Hunt about the importance of science in terms of our response to this. Science, not opinion, rules when it comes to healthcare. And Australia, I think, has been very fortunate that our politicians have listened to scientists. In terms of our own experience here at the Peter MacCallum Cancer Centre, we're the only dedicated cancer hospital. And so many of our patients come from long distances away from rural areas where cancer services aren't necessarily as advanced or sophisticated as they are available in urban centres. And we've really embraced the telehealth message very strongly to protect patients with cancer who we know now from epidemiological studies are at increased risk of dying should they get COVID-19. Relating to their underlying condition more than the therapies that they're receiving, which is something they'll perhaps come back to. But telehealth consultations at Peter Mac have increased from around 5%. We'd embraced it fairly early on because of the rural nature of our population where it was appropriate, to over 60% of our consultations now being done through telehealth. This is really a great boon for the patients, not having to travel. One of the areas that I practice in is a rare cancer called neuroendocrine cancer. I'm the co-chair of our neuroendocrine service, and Neuroendocrine Cancer Australia, which is a philanthropic foundation supporting such patients, have done a survey, and that the average distance that patients travel to get to their point of care is around 200 kilometres in Australia. This is reflecting the specialist nature of this kind of service. And that's not only the patient, it's usually a carer as well. And so they're being taken out of their workplace, out of productivity for several hours, usually a day, out of their week, with economic loss associated with that. And so to have the patient able to call in on their phone or their laptop or their iPad or however they communicate with us, and spend 15 minutes to an hour discussing their treatment, their course, and also identifying if they need to come in to a hospital for further investigation. Now, clearly, telehealth doesn't replace face-to-face. You do miss something in the doctor-patient relationship. The thing I really notice is that I take a lot of cues from the carer. When a bloke says I'm fine, and the partner rolls their eyes loudly and looks up at the roof, that they're not so fine. So that sort of body language is really important in the face-to-face that you sometimes lose. And we can't examine patients. So there are advantages still in face-to-face. So we need to get a balance right between patients coming to healthcare providers and using telehealth intelligently to improve their care. The other thing that really COVID has taught us is that patients are scared of the healthcare system in terms of the risk of infection, when in fact the hospital systems that we have in place with temperature checks and really limiting the number of visitors makes it quite a safe place. We haven't had any documented cases of COVID positivity in our staff since this all began. We have heavy screening of people as they come into the hospital, and the risk to patients is really of cancer patients is delayed or lack of diagnosis or lack of getting the right treatment. We know that treatment doesn't increase your risk of getting the infection or of dying of the infection. It's actually the underlying cancer, and so poor diagnosis, poorly treated cancer is the risk factor. And so we really want to encourage people, if they have symptoms, to get care in the way that they normally would.
Yeah, I think that's just at a personal level, I think that's a really important point, and hopefully the audience picks up on that and spreads it far and wide. I know people are quite concerned around people not actually getting the checkups that they need or not reaching out to medical practitioners in the way that they would normally because of their concerns. And it's really important, particularly with things like cancers, that people are not using this as a reason to procrastinate, but rather doing what they would normally do and should be doing. Elisabeth, are you, from where you sit, are you surprised at how well Australia has done in terms of just this acceleration of telehealth? And where do you see the opportunities for us and the sorts of changes that we might need, that we could make or might need to make in the future to really benefit from the changes we've seen to date?
I mean, we just heard from Minister Hunt about this rapid adoption of telehealth consultations, building on a certain foundation you had established in Australia. At the same point, I believe this is just a bit the beginning of how we will see digital health and digital healthcare transforming the way how healthcare is delivered. And this is on a bigger system level, of course, but the more relevant piece is the way how we as patients individually will kind of be looked after and will look after ourselves, supported by digital means, will become very, very different from how we are experiencing it today. And the learning and the opportunity from this COVID-19 situation now is that we see that it works. Yeah. We have seen a much faster acceptance. So this rate of adoption, we just heard from Rod, numbers of consultations moving from 5 to 60%. So it's this golden opportunity to really accelerate and leapfrog, and move to this future target states much faster and move to a situation where probably we'll be asking not why do we have to do something digitally, but where we ask, why are we still doing this analog? And there may be good points and elements where this will still be the best and gold standard of doing things, but there is many areas whereby applying digital tools and digital health, really the way how healthcare can be delivered and how it can be centered around us as patients will be very, very different.
I think that's a term that people have heard a bit of, patient-centred care. I suspect often we don't think about that in the context of digital technology. You know, I think from a traditional healthcare perspective, patient-centred care, people might automatically go to the sort of personal contact care, if you like. But I think what we've seen through this pandemic is exactly the point you made, that you can get the tailored, readily available support and services you need digitally, often far more readily than you can in other ways. A question to both of you, and Elisabeth, because I've got you there, I'll start with you and then go back to you, Rod, if that's okay. Where do you think the greatest opportunity is for improvements in the functioning of our healthcare system, in terms of delivering better outcomes? And Australia, like every country, is grappling with a healthcare affordability issue. So how do we actually turn technology into more affordable care and better care? Elisabeth?
mean, there is many ways of utilizing technology and investment in technology to achieve that ultimate and very important purpose and goal. And it really starts from that piece of how can I make medicine targeted and effective. And in order for medicine to be precise, it needs to be individual and revolving around the individual, but connecting to what I said just before. Because typically there is the way how medicine is delivered today, you're categorized into broad buckets, and you're maybe this, or you may be that, or you may be that. And then there is a standard treatment, which is then applied to helping that patient group. And if you now envision a world where you have a lot more specific information on the individual, you can be a lot more precise in terms of selecting what will help, what will help this individual person and patient, and not what is the general answer. And then we try to then maybe find out, well, it works for 80% of the people who are experiencing these challenges, but you're part of the other 20. And well, we just spend half a year trying to realize that this was not the best way to treat you. So I believe by using technology and deploying technology to really look at what is the exact next step which will help the patient. This is one way of making medicine also more affordable. It's maybe not the most logical way you would think of, because the logical things would, we have to reduce waste in the system, we have to make it more efficient, we have to ensure that we don't create unnecessary ways and don't overinvest in technology. And this is really not the way to look at it. So I do believe there is a huge opportunity in this personalized precision medicine. And Rod has some fascinating insights to share on this in terms of how you can actually bring this to life and make this reality by deploying artificial intelligence and other ways and means. And then, of course, there is an opportunity just in making the system more efficient by utilizing digital tools and connecting sites and connecting the hospitals and care providers across the system.
Thanks, Elisabeth, and that was a great segue into Rod. But Rod, just before I give you the stage, I am just going to remind our viewers that we still have the Pigeonhole app open. I know there's some questions there that were directed to the Minister. I'll try to pick the eyes out of those for our panellists as well to the extent I can, but please continue to log your questions there. And then, Rod, over to you. Elisabeth's given you a great intro there in terms of excellent examples, so let's hear them.
Yeah, I mean, I absolutely agree with Elisabeth that the one-size-fits-all model of medical care really is broken. We really need to individualise the treatment around the patient. We've increasingly recognised over the last 20, 30 years that even common cancers that we thought would all behave the same are very different. Breast cancer, for example, there's several different identified subclasses of breast cancer that all require very specific and different treatments. They have different outlooks in terms of the likelihood of response to treatment, of survival, and we're starting to adapt the care of patients with breast cancer to those models. But even within them, individual patients, they have variation in the type of disease and evolution of disease under the pressure of treatment. Disease or cancer is like human beings. If you put a selective pressure on them, they evolve, they adapt, and they change over time. And so the ability to characterise the nature of disease at a patient level becomes fundamental to choosing the right treatment at the right time. For me, this is something that we recognised many years ago when we started doing molecular imaging of cancer, that there's huge variation between patients in the molecular imaging phenotype, how the tumour looks on a particular scan, but also that this can not only be between patients, but within patients, that individual deposits of cancer can look differently. And if we biopsy them and we look at the genetic details of those cancers, they've undergone a new mutation or they've changed fundamentally. And so the application of precision medicine tools like genomics, like advanced imaging techniques, can actually save a great deal of money by avoiding unnecessary treatments, or more importantly, avoiding the wrong treatment. Cycling through treatment A and treatment B and treatment C sequentially, which has been the methodology that's been used in oncology, but also in most diseases, based on what we call randomized trials, where you do this treatment versus that treatment, decide which is the best. But there might be a subgroup where this treatment that's not as good in the whole group is the only effective treatment, and this one is ineffective in that particular patient. And so I think there's incredible efficiencies that are going to be delivered at a human level by understanding the nature of disease. But we have to integrate not only imaging and genomics, but patient symptoms, patient-reported outcomes. We've worked very hard to put information gathering and information exchange into the hands of patients through mobile apps, for example, where they can report their symptoms on a regular basis and feed that into their medical record or into a database, so that we can identify when patients are going, not doing so well, when they need a telehealth consultation, or where they can be just observed in the community. All of these things are going to improve the efficiency of our healthcare system. And if we can integrate that with big data, what the lifestyle decisions that people are making, companies are collecting incredible amount of information about our daily habits. If we have a gym membership, what we eat, what we buy at the supermarket. We've got incredible, in Australia, healthcare records that tell us utilisation of resources, diagnostic tests, medications, consultations. That's all available. And if we can use it as a big data, anonymise, get past the privacy issues, and then integrate that at a patient level, with specific information about their tumours or their other diseases based on a genomic or imaging basis. Using deep learning algorithms, we can learn how better to treat the patient themselves, but also groups of patients with similar diseases. And one of the areas where we're collaborating with Siemens is in the area of AI. And I visited on my sabbatical last year the AI facility in Princeton, New Jersey, where they're working on not only improving workflows for imaging patients, but also creating avatars of patients to help us to integrate all the information that we have on a patient to try and model how they might respond to different treatments. And I think this is a really exciting area of development in the healthcare sector.
Rod, can I just ask a follow-up question? So I'm a pretty big believer of the benefits of using data as well, and viewers may have heard me speak previously about the fact that I was involved in the Productivity Commission's data access inquiry, and we clearly identified what we thought were the huge benefits to better access and use of data for healthcare, and primarily to get better outcomes, as well as a more efficient and cost-effective system. But it's something that seems to be met with quite a bit of resistance. And you spoke to the privacy issues. I'm interested in, and I think there's a whole big data issue there. And again, I actually agree entirely with you, but I'm interested in what your experience has been with your patients around their appetite for data to be used to deliver better outcomes. And you talked about apps that allow them to record their own experiences and symptoms. Are you getting a sense that people are themselves getting more comfortable with that, and there is now a greater preparedness to be a bit more ambitious on that front?
Absolutely. I've been involved in generating data for new technologies for almost 25 years now. We introduced PET scanning, positron emission tomography scanning at Peter Mac around 1996, so it's almost 25 years old here. And at that time, it was considered experimental research, very expensive technology would never be clinically applicable. And there's not an oncologist now, I think, who would contemplate practicing oncology without access to that technology. Most patients are aware of it now. If they have cancer, you know, they've had many PET scans. It's widely used, but we had to generate the data. And when we started doing this, we had to get ethics approval and consent from the patients to collect their information, to follow up, to confirm whether the results were helpful in changing their management, whether they were accurate in assessing the extent of the disease. And I think in the first 1,000 patients that we surveyed on this, when we explained the motivation for this, that it would help other patients access this technology and give us information of when and how to use it, because it was limited in availability. We had one patient who said, I don't want my information shared or collected for this purpose, and that was a lawyer. Interestingly, we had from the general public there was huge take up, and with the Unicorn Foundation, now Neuroendocrine Cancer Australia, we have a mobile phone app, smart app called Planet app, where patients put in their health reported outcomes, particularly their quality of life. And again, we offer this to patients, and we've not had a single patient who said, I don't want to do this unless they don't have a smartphone or a laptop that they can use it on. We have incredible interest in this, particularly in a rare disease where there's lots of healthcare practitioners involved in their care. It's a disease that crosses beyond cancer into endocrinology, affecting the heart, affecting the psychology, affecting the hormone system. So endocrinologists, there's lots of people involved, gastroenterologists. And so the patient themselves becomes the curator and the social network coordinator of their healthcare network. And I think, what COVID has taught us increasingly is the interdisciplinary nature of the interaction between infectious diseases and cancer, for example, or between lung disease and cancer, or renal disease, or cardiovascular disease. Increasingly, we know that the virus causes complications because it involves blood vessels. And so it's affecting the brain, it's affecting the heart, it's affecting the kidneys, it's affecting the lungs. That's the highest profile complication, because people end up in ICU on a ventilator, but it's affecting all these organ systems through the interaction of the virus with the vascular system, with blood vessels in the body.
Thanks, Rod. Elisabeth, one of the things that sort of came up in Rod's response, but I think sits beneath some of the advances that the Health Minister spoke to as well, is how we get better interconnectedness across the sector. I'm interested in your perspectives on how you're seeing collaboration around the globe on some of these really important issues. What's the future for that, and how do you see Australia's engagement or connection to that?
We just heard about the complexity and the interconnectedness of many different dimensions, and I'm convinced that the only way to address this is to collaborate, and to collaborate globally. I think no single country in the world will be able to address and answer all these questions alone. And there is also an opportunity by connecting different people in different parts of the world that you can build knowledge faster and make progress faster. So for me, this COVID-19 situation is a very good reminder, and also maybe also a catalyst for driving this international collaboration even further. I mean, we may be a bit impacted now by not being able to travel as much as we used to, which was a very important part of collaborating globally. But I do believe that also here technology helps, and the fact that we're having this conversation here now, being in very different locations, shows that you can build connections and build collaboration even with severe limitations on being able to travel. Now, coming to the point, where does Australia fit into that overall network? I'm always impressed, I have to say, by how connected and also how well integrated these leading researchers in Australia are with the rest of the world. And for us as Siemens Healthineers, we rely a lot on collaborating with leading institutions globally, on really pushing the boundaries of what can be done, on exploring new technological possibilities, which we maybe can open up and look for ways of putting them into good clinical use to create real benefits for patients. And we have a number of very really rewarding and mutually beneficial research collaborations with institutions in Australia. So for us, Australia also is an important source of innovation for the world, for the things we do.
That's one, it's fantastic to hear, but I think it's interesting because often, I guess we probably don't put enough of a spotlight on that. And I think I feel personally there's an opportunity at the moment, given the high profile involvement of some of our institutions, including in the search for a vaccine and things like that maybe there's a moment in time to help shift the sort of perception that we have in Australia that we don't do enough of this, or that we can't compete, or we don't make enough of it. And I know I'm being a bit generalist here because I know there are isolated examples that we're very proud of and that we do point to a lot, but it feels to me in your comments like that ability and capability is broader and deeper than perhaps the Australian community is aware of. What do you think would be important to, from either a policy perspective or a shift in emphasis in Australia to get us to make more of those opportunities?
There always is multiple factors you need to bring together in a successful way to make it work. So you need institutions, be it universities, research centers, which have the necessary infrastructure in terms of just the setup they have, but then also the funding is an important piece, and then of course also the kind of people you can to bring together in such institutions, and then equip them with the necessary resources to do leading edge type of research. And we've truly, as I mentioned before, we've built some very meaningful research collaborations and relationships over the years, which do make a difference. And here my recommendation or request would be, make sure you keep doing that. Make sure that the funding doesn't stop. Because especially when you go through a time of economic challenges, like Australia is facing it now, like everybody else globally, connected to the impact of COVID-19. It's easy to cut budgets, and especially research budgets which don't produce an outcome exactly tomorrow, are a bit vulnerable in such a situation. So just constant reminders how important it is to sustainably work on these topics may be very helpful from my perspective.
I think that's going to be an issue that's going to be quite topical, I suspect. In Australia, we're already seeing a little bit of the conversations around it, and whether and how we fund it in the future, I think will be not just a question for the budget coming up this year, but for budgets for years to come, I suspect. Rod, you were nodding there. What's your perspective on that?
Yeah, I mean, I agree very much with Elisabeth. We need an interaction between laboratory science, translational medicine and clinical medicine, and integrate the resources of industry partners in this matrix. I think Australia has really been very well served by the development of the Medical Research Futures Fund, which has had the ability to fund some clinical trials, but also partnerships with industry, things like the Frontier grant process, where industry can collaborate with academic partners. And this has been, I think, very warmly embraced by not only biomedical companies in Australia and SMEs in Australia, but also by international companies. Unfortunately, the latest round was pulled, I think, about half an hour before it was due to close because of the outbreak of COVID-19 and concerns, I guess, about the ability to fund it or what the impact on medical resources and how reallocating funds to research into the COVID-19 would potentially impact on other areas of medical research. But this is a great opportunity. I think, I'm, as you can see, been in the business for a while. I started my medical career at the time of the Aids epidemic, which, posed great uncertainty for the world at that time. And we learnt incredible things about the way that the viruses interact with us as humans, how they impact our immune system, how they can cause cancers, how to treat them, new treatments. But in the process of that, we understood the immune system in a much more intimate way that has led directly to the whole expanding field of immune checkpoint therapy and cell-based therapies. And so areas of research that don't seem immediately relevant to one area become relevant in another and can lead to huge advances. I'm a bit of an amateur historian. There's a beautiful book by a guy called Norman Cantor called In the Wake of the Plague, and it looked at the economic and social changes that occurred, but also the changes in the human genome that occurred through selection related to the Black Death, the plague that hit Europe. In the 13th and 14th centuries and through to the 15th century, fundamental changes to society. And I think that COVID-19, in the same way that cancer's been with us for millennia, so is infectious disease and pandemics, that we're going to come out of this as a different society with different tools, different perspectives on healthcare, and new learnings that are going to improve what we do. And I think as long as we can keep engaged with the politicians, that they're going to listen to science, they're going to have policy with evidence, that we're going to fund both fundamental research and translational research and clinical trials with the recognition that there is sometimes not an obvious clinical application that may come out of something that's a good idea. And the NH and MRC are changing the way that they fund fundamental research, in my mind, perhaps in an anti-collaborative way, because you're limited on the number of applications or the number of people who can be on an application. But at least we're balancing that with things like the MRFF grant system, which is about building teams, about building collaborations at multiple levels: academia, industry, SMEs, large pharmaceutical, large instrument technology companies like Siemens.
Can I take you both to the question of data, because so much of this, I think, rests on access to data in terms of being able to use the artificial intelligence, etc. There is a question we've got from one of our audience members around, what your views are on the right data settings, if I can put it that way. What are the right protections that we need, and perhaps just reflect on the balance of consent, de-identification, and how we get that right so that we err on the side of being able to do as much as we possibly can, but still being mindful of people's concerns around privacy. Perhaps first, Elisabeth, to you, and then Rod, I'd like your views on that as well from an Australian perspective.
This is a very important and also very difficult question. It's, I think, clear that there have to be mechanisms to protect privacy in the midst of all the opportunities which unfold themselves with big data. And I do believe that there is a lot of possibility by just anonymizing or de-identifying data and making sure this is done in a smart and professional way so that it cannot easily be traced back to the individual, and thereby really making this information available for the bigger good, in a way. At the same time, people need to have a choice. They need to be able to say, I want this or I do not want this. And I also expect that this view to how protective people want to be of their own data maybe also will change, because we've experienced this also in the past few weeks and months, that just some benefits which are accessible by sharing a bit more, and the tracing apps are a good example, is where if you are willing to be part of this network, you can really make a difference. And if we had this kind of debate without having the challenge of COVID-19 affecting our lives, I'm sure there would have been no way this would have been accepted by the population. And even now, of course, there is many different voices and there is many ways of looking at this topic. But in general, my impression is that the willingness to become part of this larger network where people contribute, exchange, and also benefit from data being provided by others is growing.
Rod, what are your thoughts on that, and particularly mindful of this sort of Australian attitude, which I think has been pretty risk averse on this?
Yeah, certainly. I think that one of the aspects that people don't realise that unwittingly they're providing an incredible amount of information about themselves. Every time they go on Facebook, every time they hit a website, they Google something, there's an incredible amount of information being gathered about us that's not being used necessarily for our benefit. That there is a fantastic opportunity if we could garner that same information around and link it to healthcare outcomes. Incredible opportunity to understand the epidemiology of diseases, the risk factors of what's causing disease in individual patients, what's protecting them against disease. There's a fantastic opportunity there. The second thing that I think point that needs to be made is that companies like Siemens can do incredible things in terms of computing platforms and AI algorithms and so forth. They have incredibly great scientists. They have lots of resources to do that, but they don't have patients. Doctors have patients, hospitals have patients. And so getting that link between availability of information and getting it to the people and the resources that can bring them together to help patients, I think is incredibly important. One of the things that I think has really impaired data gathering in the medical healthcare system is not only the privacy issues, which, as I said, I don't think most patients who are sick have any fear of sharing their information if they think it might help them or other patients. That's not the issue so much. It's the well person who's worried about getting sick or that worries more about that. But the patients who actually have disease, they're more than happy. They want their information out there. They want it integrated. They want information about the best treatment for them, how they're going, what their prognosis is, what the best treatments are going to be. So we need to empower them to share that information. And a lot of the work we've done around the patient-reported outcomes and databasing is to make the patient their own data manager. They know when they have a scan, they know when they have a medication, they know when they go and see a doctor, they know who their doctors are, and they're more than happy to have all their information shared at least with them. And I think that's going to be really important, that the data managers, human errors, they're less got less motivation to collect that data, put it in a timely manner than a patient has. But we need to, at the same time, give information back to patients that is useful. The app that we have on the phone, they can look back at what their symptoms were like a month ago, a year ago, because who can remember how they felt a year ago? You know, it's hard to remember how you felt last week, let alone how you felt last month or last year. And to have something that's a qualitative scoring system where you say, you know, do I feel stressed? You know, how am I sleeping? You know, what are my bowels like? All of those things which are important to our appreciation of health are something that we have a very poor memory of, but computer programs don't. And so databasing all of this information, then integrating it with the treatments they've had, we can work out what works, what improves quality of life, what diminishes quality of life, what impacts survival in these patients, whether it's from infectious disease, rheumatology, cardiology, cardiovascular disease, you name it. This is going to be critical to the future of healthcare, in my opinion.
Yeah, I couldn't agree more. And I think some of the points that you hit on were things that we sort of picked up in the Productivity Commission work on data, which is just some of the contradictions around people being prepared to essentially give away a whole bunch of data for, you know, through Facebook and things like that. They could see the benefits. The benefits were they could connect to people. And so they've seen that. I think one of the things we absolutely have to keep doing is stressing what the benefits are and reminding people of what those benefits are. They're very obvious when you're sick. I think that, you know, people are looking for the very best treatment. I feel like through this pandemic, we've seen a shift in the risk appetite as well, that people have been prepared to accept things, accept change faster because they could see what the risks of not doing something were. And so I think that's part of the change in the conversation. But for my mind, I think continuing to advocate what the benefits are in a very personal way for the community is where the answer lies in this. But there's a long way to go in creating confidence around some of it. And I think, Rod, your point about the more we share that information back with the individuals themselves and give them the sense that they can use it for their own benefit as well, the better off we'll be. Sorry, you were going to jump in.
The Red E in CEDA around economics, you know, I think in healthcare we have to get far more sophisticated in the way we analyse the economics. In my own area of imaging, you know, often the studies are comparing the cost of a CT scanner with a PET scan or an MRI with an ultrasound. And it's ludicrous. You know, I remember sitting with a professor of economics at the University of Melbourne while we were doing scoring at my son's cricket game many years ago. And he's a microeconomics guy, was talking about how they determine the fraction of a cent here and there that goes into making the case for major infrastructure development, like a highway or a new airport. You know, the fractions of a second of time saved in productivity goes towards looking at the value proposition that exists in there. We don't do that in health, I don't think. I mean, maybe that's happening at the Department of Health in a way that I don't understand, but I look at the evaluation process of new technologies, for example, and it is so clunky in terms of economic evaluation. It's, you know, cost effectiveness, you know, in quality life years that really aren't measured very well at all with very blunt economic tools. And I guess in this audience, one of the pleas I would make is that really economics has to drive healthcare. You know, we have to get sophisticated modelling of healthcare outcomes, investment in research, investment in health infrastructure, in data management and data collection, and the integration more seamlessly of the resources of industry and academia. You know, that's why I know that many of the companies that we deal with here at Peter Mac are incredibly interested because of our specialist expertise, but also because of the access to really specific patient groups which are of interest to them. And so I think this is all going to come down to an economic analysis when we get out of COVID-19. But we need better tools, and we need partners to help us do that piece much better.
I couldn't agree more. And one of my little hobby horses as well is when you look at new technologies is understanding how the rest of the system has to change in order to make the most of them. Because if you put new technologies into a system where you don't change any of the other moving parts, then you might end up actually not realising the totality of the benefits and the cost savings that you could, because you're sort of not realising the full opportunity set of those changes. But let me finish off. We're fast running out of time, as I knew we would. With the question to both of you, it's come through a couple of questions from the viewers. And I think it goes something like this, really, that I mentioned this before to the Minister, that the cost of healthcare and access to healthcare is an issue around the world. Australia's got a fantastic healthcare system and one that affords very broad access. But I think there are concerns in people's minds about the extent to which technology will eventually lead to lower costs and more accessible healthcare. And is there an issue as we go increasingly to telehealth that some people get left behind from that? Elisabeth, maybe start with you, if you wouldn't mind.
When we hear about this cost of healthcare and the accelerating and escalating cost of healthcare, there often is this equation, and it's the technologies and the more expensive devices which are driving this and are kind of at the background of pushing cost upwards. And it's actually quite interesting to know that today, if you look at total healthcare spend, actually less than 1% of the cost which is spent on healthcare goes into technologies driving and improving productivity in the system. So there is a lot of opportunity by leveraging technology around different angles to actually contain healthcare cost and thereby ensure better availability as well as accessibility to the population in a country. When it comes, will people be left behind? I don't think so. Yeah, because this telehealth, it's a real opportunity to improve access, to make it easier for people to access medical resources and care. And I don't really see that this could lead to a scenario where we would not be able to deliver more varied and more layered care to the population. So really, I think this is predominantly something which will help. And I don't see a very big risk that it will exclude people or leave people behind.
How about you, Rod? What are your views on that?
Well, I actually think that the digital revolution is democratising healthcare. It's making access to opinions and data much more accessible throughout the world. We have many patients who contact us through the internet for an opinion. They can send us their scans. They can send us their genetic details. We have an incredible ability to deliver healthcare globally now, that we're doing teleradiology as well. We have patients coming from New Zealand that we do a multidisciplinary team meeting with the clinicians and the patients in their home country. These are incredible resources, I think, that are going to make healthcare truly international and much more accessible and much less dependent on what expertise and technologies are available locally. I was involved in a Lancet Oncology Commission looking at this very question of healthcare cost and whether we can afford it in the West, let alone the developing countries. Can the developed countries afford healthcare? And in that analysis, we found that the cost of therapy was around 96 cents in every dollar, and yet every therapy that's delivered is based on a investigation, a set of investigations which makes the diagnosis to determine the treatment. So if we don't select the right treatments, we don't deliver them at the right time, we don't monitor them accurately, we're wasting money. And there's huge productivity gains by some of these higher technology investigations that can lead to precision medicine, not using a treatment that won't work, using one that will, stopping treatment that's already had the desired effect at an earlier stage before you get toxicity, or monitoring toxicity and changing treatments on the fly. All of these things actually save money. You know, there's huge cost in the toxicities that we develop during treatments that are either ineffective or unnecessary. And this is a huge opportunity for the world to actually rationalise our healthcare by better selecting the treatment, better monitoring it, not using treatments that aren't needed, observing patients to work out when to intervene, to use telehealth to help us select which patients need investigation and when to do them, rather than doing them on a recipe book. That you know, as I said, my view is that the one-size-fits-all medical model is fundamentally broken. We have to change that. We have to move forward and do patient-centred care at every level, collect data that's patient-relevant, do imaging, do diagnostic tests that are patient-centred, not provider-centred. You know, we want to get away from, you know, people saying, I want to do this test because it gives me a good profit margin. It needs to be about what's beneficial to the patient, and let patients actually have access to that information so they can make informed choices and be curators, as I said, of their own healthcare, advocates of their own healthcare.
Oh, thanks, Rod. That's actually a fantastic note from both of you to finish off on, I think. What an interesting conversation we've had, starting off with the Minister earlier on, outlining how he feels we've done well and the challenges ahead, but also the opportunities for Australia to lock in around telehealth and to think about how we can continue to improve the system. Really heartening to hear that so many in the sector are working together behind these big systemic changes, which will deliver better outcomes for the whole community, really. If I can pick up on just a couple of other themes that I think are really worth underscoring, Elisabeth, I'm just not going to let us forget that from your perspective at Siemens and sitting outside of Australia, that you're keen to remind us that you get lots of really great innovative ideas coming from Australia, that we have really good capability, fantastic people who are sort of leading the way amongst their global peers. And I think if there's one thing that we really grab onto out of this crisis, it's knowing that we can do that, and we play a vital role in driving real change, not just in Australia, but around the world. Of course, acknowledging that comes with a reminder from both of you that we must continue to fund the research and the innovation that's been so critical, not just through this crisis, but more broadly. So I guess a message for those setting budgets there. And I think, Rod, just to really bring home your comments around patient-centred care, I think it's a term that people use a lot, but when you speak so directly to it and you talk about the cost to the system, but sitting beneath that, the very real cost to individuals of a sort of a guesswork approach to medicine and the implications that can have for them, bringing data, bringing technology to personalised care in a way that actually delivers better outcomes is something I think we can all aspire to. I think it comes with a message to policymakers to get the right settings, but I think it comes with a message to the community that there are real benefits in there for them as well, and maybe we just need to focus on those benefits a little bit more than some of the risks that tend to dominate the conversation around privacy, for instance. So a very, very rich conversation, as I fully expected when we set out. I did remind you all that when we started off that we had a poll running. Let me give our panellists the results, as well as the rest of our viewers the results of that poll. The question that we presented to viewers was, COVID-19 has reshaped the healthcare system in Australia. Many changes in the delivery of healthcare and the design of the system are likely to stay. what do you feel has been the most profound change that we've seen through this crisis? 35% of viewers said service delivery. Digitisation of health, of course, 50% flagged that as the biggest change, and a greater reliance on collaboration at 15%. I think collaboration sits beneath a lot of these other changes, so I think we shouldn't lose sight of that. But obviously the digitisation of health, as shown by the rapid take-up of telehealth, including the numbers that you quoted, Rod, right up there. So thank you to our panellists for participating today. Elisabeth Staudinger from Siemens and Rod Hicks, I've forgotten, from the Peter MacCallum and Melbourne University. I'm sorry for not rolling off your titles. Can I just remind our viewers as well that in addition to these live streams that CEDA has been producing on a weekly basis, there's a tremendous amount of content also available on our website. That includes recordings from previous live streams that we've done, podcasts, blogs, and a whole bunch more. So if you've enjoyed today's live stream, please get online at ceda.com.au and have a look at the content that we've made available there. And before I go, I'd really like to acknowledge the important contribution of our sponsor for today, Siemens. We've been putting these live streams on since the middle of March. Our viewers would know that we shifted very quickly to the online delivery of content. Members know that we're not charging them for these live streams, and we couldn't do what we've been doing. We couldn't produce these live streams and as many of them without the fantastic support of our sponsors, and sponsors like Siemens, who are incredibly loyal supporters of everything that CEDA does. So a big call out to Siemens for their support today. Thanks again to our participants, Rod, Elisabeth, and Minister Hunt, who's departed earlier. I look forward to having you participate in future live streams. And with that, I'll say thank you for joining us today.
Thank you. Bye-bye.
Thank you.